Very good morning, sir.
Good morning to all. This is Chandramohan, ortho physiotherapist from Sri Samraj Physiotherapy Center, Dindivanam, Tamil Nadu. A warm welcome to all for the ExRxIndia's and Sri Samraj Health Services Private Limited's presenting Webathon, a web series, endorsing for the world record in the field of physiotherapy, not just counting the topics, but responsibly providing the knowledge for the physiotherapists in India and 25 other countries. Apart from this, ExRxIndia and Sri Samraj Health Services is providing online OG consultation for the women's health-related issues in association with Pickle Studio Chennai, where our co-host Dr. Rupesh is a co-founder of this, and Dusat Creations from West Bengal. This is our Professor Duna's concern, and this program is powered by Fitness and Rehab India YouTube channel and LARC, Lalit Academy and Research Center. I take opportunity to wish all the physiotherapists globally a very happy World Physiotherapy Day. And ExRx India's final days, first webinar. We are having 3 webinars today, and the first session is ACL Injuries in Women. Will be presented by, before I read his name, I would like to tell that he is from India, especially from Tamil Nadu. He belongs to my batch, and he was referred by a professor, Dr. Lakshmi Prabha. He is working in Australia, an Indian who works for Australian sports team. So I feel very happy to have him in the first session on World Physiotherapy Day. I welcome ExRx India team members, Dr. Vairav, Dr. Rupesh, Professor Duna, Simran, Alisha, and Uma, and all our associates, Dr. Arunachalam, Dr. Venkatesheshan, and Dr. Manoj, everyone. So maybe they will be joining now. And now I welcome our resource person, SATHYA Subramanian, and I request him to commence the session. Please.
Thank you, Chandru, for the warm welcome. Much appreciated. First of all, I want to say a happy World Physiotherapy Day and wishes to all the physiotherapists in and around the world, as well in this platform. I want to especially thank my teacher, Professor Lakshmi Prabha Madam, for introducing me to you and to the ExRx team. And thank you, ExRx team and Fitness and Rehab India channel, along with yourself, Rupesh, and Professor Duna, for organizing such a wonderful webathon series. Hope it is a great success, and best wishes, and thank you for giving me an opportunity. Hope you don't mind. Shall I start sharing the screen?
Please, sir.
Yes, welcome.
Okay. Okay, so today our topic, I hope you all can hear me. Can you all hear me?
Yes, sir, we can hear you. Please continue.
Okay, thank you. So yeah, today our topic is on ACL injuries in women. How can we prevent or reduce these injury rates? One of the number of injuries that we see in Australia, a high number of injuries since 2007 in all our sporting games, especially, we've got a great record about this. Before that, I want to just say thanks and acknowledgement to my work. This is the place that I work, and all my gurus, especially Lakshmi Prabha Madam, for giving me an opportunity through this platform, and all my physiotherapists, fellow physiotherapists and students, and some of the videos that I have taken. I'm thankful to those two people like Erica and Josh for this. Today is the World Physiotherapy Day. I want to commence this session by wishing all of you a great day, and hope the physiotherapy profession and a noble profession keeps spreading everywhere. So ACL injuries in women, why is it more than men? Normally in Australia, we see players are at least like 9.2 times more likely to injure than the male counterparts. The overall annual incidence, especially in US, especially in the collegiate level, it's about 68.6% per 100,000 person. Means in every 1 lakh people, there will be 68 people can get injured. So the epidemiology roughly in women's is roughly 2/3 of the injuries non-contact mostly. I'll show some videos a bit later. Most of these non-contact kind of mechanism involves cutting, pivoting, acceleration, deceleration, or landing from a jump, or perturbation as though someone is trying to push you during the game, like in a soccer or in rugby or in Australian league football. ACL tears most common at the ages of 14 and 18 in women, as per one of the US study, and mostly between 19 to 25 in men. Majority of these athletes involved are in high school, collegiate, or in league sports. 2/3 of the ACL tears are non-contact. Very less is contact, as though like you're trying to contact with the knee of a person, or you're trying to, as you jump land, someone is pushing you, and that's a kind of a contact as well. So gender disparity of ACL rates was first published in the year 1994. When the women's sport started to increase, especially from contact sport kind of sports like hockey, field hockey, ice hockey, basketball, and the recording numbers of ACL injuries have increased over that period of time as well. So if you look at a quick anatomy of how the ACL looks, just thought of, this is still an arguable area. Quite a few people say there's no bundles or there's no kind of cross-sectional areas, but to understand this, the anteromedial bundle, which always tightens mostly at knee flexion, and it is mostly in the proximal area, and posterior lateral bundle, which tightens at knee extension. There is still a bit of disagreement exist on this. Also, there is a reciprocal tightening could also be possible. So the main structures that are present, or the receptors that are present in an ACL, are the Ruffinian, the Pacinian corpuscles, and the Golgi tendon organ, and the fine free nerve endings, which are all responsible for proprioception. By chance, if someone has sprained or strained their ACL, within the period of 2 weeks to 6 weeks before their surgery, there's a likely chance that they might lose these mechanoreceptor properties, which are responsible for balance and coordination. So we must ensure or keep this in mind, understanding how this anatomy plays a major role in our rehabilitation. So some of the biomechanics and the rotational stability, which is what we should understand about ACL, how it works. It is a primary restraint, means it holds the knee joint in position, especially anterior tibial translation, when the collateral ligaments like your medial or the lateral collateral ligament ruptures, or even the capsule associated with it. Also, if there is a chance that the joint opens side to side, ACL and the PCL are the secondary restraints providing other than your collateral ligaments. And the ACL knee structures limit mostly the internal rotation and the anterior tibial translation, which is similar in a pivot shift mechanism. I think you all know how a pivot shift testing is done, which is another reason for us to find the integrity of the ligament. Quite a few studies have proven that how it works in almost all the cadavers, as well in the live studies. If we look at the mechanism, quite often women are more prone to develop this problem of hip adduction, internal rotation, along with a knee valgus and a tibial internal rotation also. This causes an amount of strain on the medial side of the knee joint, which apparently puts the ACL under risk, and the ACL starts to move forward and ends up in a strain or a complete rupture, which is slightly opposite to men. That is purely because of certain risk factors that we're going to see in next few slides. Quite often, sagittal plane is mostly seen in men, but it is still arguable that men also have quite a few non-contact injuries. Without any contact, they get injured, and the mechanism is still seen in those kind of scenarios. Here is a video I'm going to show you how a non-contact type of injury that happens and what happens in this kind of injury. This is one of a female football player who gets injured when she was trying to move and trying to do a cutting or a pivoting movement when she is trying to do it. Why and what happens in this? Quite a few of majority of the injuries happens this way. And females have a weaker ACL comparing to men because of the size difference they have. They have a poor neuromuscular control, and and the knee stability is also poor. Watch her knee now; she's strained it already, and she's on the ground. And there will be a slow motion. It is slightly distressing. Don't get upset by looking at the video, like, what happens to this person. You can see how important the muscles, the ligament, and the bony geometry that provides the stability to the knee. It's a slow motion, and you can see it's a valgus strain that happens at the same time. One of the research in 2009 suggests that non-contact ACL injury, and especially in multiplane movement loading movements, it is more not only just an anterior translation. It is more than that happens to the knee joint. So in this scenario, we know what body position is important, how it works, like abnormal body mass load, and how this matters a lot. So anterior shear happens here, then the valgus collapse. It is still a bit of a debate goes on whether the valgus causes the injury or is it just a result of an ACL tear. It is still unclear. And the transverse plane, which is like rotational movement that can also cause. The other reason is foot placement, whether the foot is away from your center of body mass, and poor trunk stability and posteriorly placed body. The person is leaning backwards and not able to control their body, and then there is no chance for them to recover from that position, and the knee has to take the load, and the knee gives way. And hip internal rotation is another problem, along with the hip and knee flexion angles. And excess hip adduction. Quite a few people are knock-kneed positions, and also due to wider pelvis, whether that is becoming another reason for them to have a problem, it's still questionable. There are certain questions we can ask as per Hashimi et al., who are one of the leading researchers from US, and then they put some questions. What happens? Why we are looking at this ACL mechanism, especially non-contact? What is that inciting event? What happens exactly in that event? What muscle forces, joint torques and loads? Is it really physiological or is it biomechanical? How much mechanism of injury is time requirement, for you to recover from that position, whether you are able to recover, because everything happens within 0.5 millisecond, means it is only half of what you think about. And by the time the bus is gone already. The fatigue, how much fatigue plays a major role in the neuromuscular control. The plane of movement, what are the planes in which this ACL can happen? Quite a few would have seen in hyperextension, it happens. In people with internal rotation, it happens. In people with adduction, hip, knee, valgus position. And some of the geometry, how much that affects, anatomy of the knee joint. How is the femur versus tibia? What's the tibial plateau in the femur notch? Is general hyperlaxity plays a major role? Is there a gender biased, for example, or gender-based disparity? For example, like men compared to women, menstrual is major role. So those roles are some of the risk factors that they are finding, and how much is it viable? How are we able to understand this is what we are trying to do in this condition. There are certain risk factors that we see. It is still debatable. There are some external factors and versus internal factors. What are the possible external factors that could be causing a trouble here? Could be one, the surface that they play. Quite a few often it's less directly related to ACL injury. You know, either it is a hard surface or a wooden surface or a rubber synthetic surface where they play in European handballs, or in the shoe. Shoe sometimes plays a major role, especially the cleat type of shoes or rubber studded shoes. They found one of the study in America has shown that they have a bit of increased number of studies, especially people wearing a longer studs in their boot, especially in the NFL league. Weather and temperature or bracing and taping, they don't have enough evidence to back it, and it is not able to concretely say that that can protect or prevent an ACL occurrence. However, they have shown some studies that there are some artificial surfaces that can cause or can increase the amount of ACL injuries. So the intrinsic factors plays a major role, which is within your body, which is under your control, but also it is your geometry. So anatomical, hormonal problems, neuromuscular control, core stability plays a major role here, biomechanical issues, people with loading control or different planes, and family and genetic problems. We're going to see slightly elaboration about these factors. So if you look at the anatomy of the knee joint, why women are more prone to develop non-contact injuries, purely because of the femoral notch is very small comparatively to the men's side. There is an increased correlationship on this one, especially in adolescent athletes. This is very much seen purely because of the growth factor on pre-puberty and puberty level. The size of the ACL, normally the size is between 31 millimeters to 36 to 37 millimeters on an average, and it varies based on your hyperextension versus flexion at varying angle. So is it a small length that is causing a trouble? Yes, there are some women who are smaller in ACL. Also, the cross-sectional area, not that wider, and it is not as dense also. And very low mechanical properties. For example, people who have not run, who have not done any activity, suddenly they are much more prone due to the family, or everyone is saying that they have to start fitness and running. So those are all poor people who may get injured, and poor ability to withstand load, which has a huge relationship with this. However, we need more research on this, on biomechanical study and anatomical study. In joint laxity, if you look at it, or ACL laxity in general, women are more prone for this. Knee joint hyperextension is another causative problem because of general laxity. If there is a dynamic hip knee valgus angle, that also plays a major role. People with broader pelvis versus cross knee position, which is the quad angle, which we will see a bit later. Patent score is something that I predominantly use to understand some general laxity. It has good reliability on it, but what happens is it is not as specific. It only tells you generally whether the person is laxic or not. You're able to score between 0 to 9. If someone who is more than 7, then 7 out of 9, we say that generally that person is laxic, that there is a chance that they may get injured. For example, in the sport like gymnastics or calisthenics, contortionists. So those are all the people who may be much more laxic. And the foot pronation, how much the foot pronation plays a major role, especially in navicular drop. One of the presenter the other day at ExRx was talking about navicular drop, how much it causes internal tibial rotation and the shearing force and the torque that changes. Predominantly, this is seen in female population. And the risk factors, if you look at it, another side of this is the body mass index, how much that plays a major role. This causes increase in body weight, causes you to have a bit of hyperextension. When paired with a small notch and the ACL size and increased knee laxity, then these people are more prone to develop injuries. So it is still a bit of controversies are there with how come all the obese people, when they're participating in sport, not getting injured. Still, it is not been proven, but definitely it is mostly seen in the adolescent and young athletes. And we have seen that quite often, both in Australia and in America, and as well in European handball game. Q angle, if you look at it, you know, the quadriceps angle, how much this plays a major role with respect to increase in shear force that happens onto the anterior tibial translation versus internal rotation of the hip versus high valgus force as well. So pelvic width plays a major role. So you must understand, if someone is coming, it's worth to do a screening for this kind of population, especially adolescent age group. The other day, Dr. Ali Rani was telling that physiotherapists must start screening all the children at school, or they must be employed at school. You know, that's a very valid point. I totally agree with him. Like any other nurse, the physiotherapist must be there. In our clinic, we have employed 3 of our physios going and doing screening as well, managing 2 days in a school. So I'll promote how to screen these people. That's very important. The other side of the anatomy is the tibial slope. We must understand how much tibia and its slope plays a major role. You can see as per the sample picture that I have provided you here, how much that angle that plays a major role. Mostly women have increased posterior tibial slope. Then what happens? That plays the knee slightly at the chance for it to translate forward because of the position of the tibia that is present. So, but again, it is a bit of a single condition to have this problem. But what we have seen is this is quite often seen in women, and meniscal slopes can actually add up to this problem also. So other risk factors which plays a major role for women is hormonal risk factors. Estrogen and progesterone, you all know, that plays a major role, and it inhibits quite often the fibroblastic growth and in the collagen, because it has that ability in the ACL, and they have done some in the cadaver studies. So this, along with the progesterone, which also attenuates the function of estrogen, so it doesn't allow the collagen to repair or collagen to develop properly when they're entering into the puberty stage or in the maturation stage. So we have to be really careful how much this plays a major role. The other reason that we have seen in some of the studies is on the menstrual cycle. You know, the menstrual cycle has 3 different phases: follicular phase, pre-ovulatory, ovulatory, and the luteal phase. Quite a few of the studies, when they have done urine and saliva studies, they have found a huge amount of sex hormone concentration along with increase in estrogen and progesterone. So there is increase in relaxin also. Along with this, you know, that's a perfect concoction for you. There's a chance that you will get injured. And most of the studies are saying that it happens in follicular and ovulatory. Why am I saying this? Because we must understand there are certain young athletes who are coming and whom you become the physiotherapist. You should understand what their psychology, what's happening to them. Try to win them, try to understand them, so that the player will also open with you. They'll be sharing what is happening in and around them. And you can adjust your training program accordingly, and especially some of those prevention programs. The other side is oral contraceptive pills. The oral contraceptive pills, it is not completely proven, but more research is needed. But what they are saying is, if people who are taking over a regular period of time has the ability to reduce the ACL risk. But remember, oral contraceptive pills, what it can cause, it causes the other side. You know, your menstrual cycle doesn't happen properly. There is a chance for you to suffer amenorrhea or even dysmenorrhea. Those kind of problems can happen because of irregular cycle. Quite often I have seen female athletes wanting to take pills because they have got high game coming up. They don't want to be really lethargic or fatigued or anything. They don't want to get injured. They go for this as a continuum. Quite often the general practitioners do prescribe here. Some of the neuromuscular factors we must also understand here is the subconscious control and the pivoting mechanism that happens along with alteration in your movement pattern. There's a huge biomechanical relationship here. We must understand what happens to you when you have a fatigue, when your muscles are fatigued. Say you have played, say 3 sets of tennis and you're fatigued already, but you have to go further, or you have to play another game in the same day. Then the fatigue, then the stop and the jump landing can cause, again, that movement pattern of you ending up in ACL injury. So quite often what we found in one of the study, they said that there is a huge electromechanical delay when they did the electromyographic study, that the eccentric hamstring control is reduced in some of the people. Then what happens, there's a chance for the anterior translation along with internal rotation can happen, because that is reduced in some of these people, and there is a poor mechanical response relating to that. So other thing is altered muscle activation. If the muscle is not functioning in concurrence, especially when you're landing and cutting, especially those kind of maneuvers where you are trying to do a movement when you're going to go side to side rotations, there is more quad control and the less hamstring control here. And this can be measured in isokinetic machines, or as well in a dynamometer. Like a handheld dynamometer is another valid tool that we can use. Specific exercises are done as a warm-up, and it is spent for 15 to 20 minutes as a preparation exercise before a game, before a training session. That activates these muscles and helps them have a better warm-up. So you are trying your best to prevent these injuries. The other thing is inadequate muscle stiffness. When I say muscle stiffness, when we compare men to women, women have poor knee stiffness in general, and they are unable to control the knee, especially when they go at 45 to 60 degree of knee flexion or even beyond. When the hips and knee come to that position, then there is a chance that knee stiffness is unable to hold, especially the long tendons. So the males have a huge longer activation of gluteus and gastrocnemius, which holds the knee joint in place, and that helps the hip under control, also prevents excessive anterior tibial translation. So future research on this, especially on females, is needed. Quite a few physiotherapists are here on this forum. You can definitely try to research on this. Where in India, you can see quite a few women are taking sport as major kind of professional area nowadays. It's better you can, if you organize yourself or get a job, please do some, associate yourself in doing some research on these. Some of the other risk factors, biomechanical versus genetics, you can see when you go to a safe position versus no return. Mostly the safe position is when your hip abductors and your gluteals are working together along with your knee flexors, which is your hamstrings, and your calf muscles, which is your plantar flexors, and the landing pattern, how you're going to land. And going into a point of no return is basically your adduction of your hip and internal rotation, along with a valgus position of the knee joint and externally rotated or internally rotated tibia, along with a foot in a pronated position. These actually, in a different planes of movement, we are able to see. Quite often the sagittal movement can happen. It is not clearly proven in females whether they are getting sagittal based, like an anterior or posterior only, like in a hyperextension or a anterior translation movement alone. But coronal, which is involving an increase in valgus position, hip adduction, internal rotation, and ankle eversion and foot pronation, this is a quite often seen injury. And genetics wise, women are more prone to develop injuries if there is a family history. And especially the parents, if the mother or father who have injured, then there's a 2 times higher risk, especially the collagen genotypes. They found some genotypes that are present in people who are prone to develop this kind of injuries. To summarize all these risk factors for us to understand, so we must understand the anatomy, how the anatomy of the knee joint is important in preventing women's ACL, and we must realize how the person is, how the hip knee position is when we do the screening, and range of motion of the hip, knee, ankle, and foot. Biomechanical abnormalities, if the person is unable to participate properly or unable to have that control when they do high cutting, maneuvering movements, and core stability that plays a major role also in maintaining your upper body and the core between your lower body. And reduced hamstring strength ratio between the hamstring and the quadriceps, there is about 0.8 of contraction of the quadriceps versus 0.5 of contraction to the hamstring. The hamstring is unable to match the quad because the quad is highly an eccentric anti-gravity muscle. So that emphasis is made that part of a training regime must involve hamstring strengthening program. Other factors, all the other factors have to be considered, either the family history, other history, we have to take it. the main scoring system that I predominantly use, which is a high valid and high gold standard, is a landing error scoring system. This you can find in Physiopedia. If you Google, you can go look at Physiopedia, and they have given a very good explanation. They have a video on it, how to do the scoring, and they have got some Excel format as well for you to score, and people can download it. It's a very good platform for you to understand which are all the exercises and screening tool that we can do to help us to program an exercise program. So the ACL injury reduction programs. So from what we have looked at it now, in the year 1999 to 2009, quite of the emphasis to prevent ACL injuries were on neuromuscular training, which alone is not enough. After that, from 2010 to the last decade alone, quite a few combination of training have come up. For example, like warm-up, good core stabilization like planks, side planks, wood chopping exercises, some balance and dynamic stability, hamstring, especially eccentric hamstring, a few Nordic curls, hamstring rolls on a Swiss ball, plyometric activities, jump landing activities, change of direction activities, any other sport specific, for example, tennis or even cricket. You can find some sport specific drills that the strength and conditioning coaches nowadays administer before they start of the game or before they start of the training. And this is performed pretty much during the preseason as well in the in-season. And dynamic stretches, all the dynamic movements as a part of their training so that the injury risk can be minimized. Whether can we minimize it? We're going to see in the next few slides about it. So some of the programs you can see as per the picture that is given, how the emphasis is done on landing, how a person is going to land. If you jump land or if you do a cutting landing positions, how well you're going to land yourself, how well you're going to move yourself. And progression of these exercises are very important based on the level of play they do, whether they are very elite or sub-elite or in a club level, the sport is still the same. So we must ensure that the ACL reduction programs are administered, especially in women population who are in sport which is involving a lot of cutting and turning maneuvers. So poor jump landing and body position. This is something we must correct all these players, ensure that they are not landing uneven. They are not bringing their knees together. They are not placing their foot one in front of the other, or moving their body weight away from them, or leaning forward. Their line of gravity is not within them. These kind of cues have to be informed to those players. Sometimes you can even take a video and show them, hey, look at this. This is how you're moving. Maybe we should stop this way and try to change your line of gravity and your body position also. That might help them to move better and prevent such an injury, because it's such a toll on the player, and it takes a lot more time, money that they have to spend to rehab themselves, and it is a huge psychological problem. And they have this fear avoidance that they would not want to either participate in the same sport again or returning to sport. The drop-off from the sport is huge amongst these players. Also, their compliance with these exercises. We must ensure that they are very compliant with these, and the frequency of doing these movements are very important to emphasize them to keep moving better. So low risk and all these change of direction techniques, we must teach them what is low position. You must bring your hips and knees well down, ensure that the foot is not moving too much away. When you're going to turn yourself, how to turn and how to pivot your body. Especially in school-going children, we must be next to the physical educator, and we can tell them what all the mistakes they are doing. Sometimes you can take a video and help them and change their body mechanics when they are moving. So one of the video that I'm going to show you here also, it's a bit distressing for you. So look at this, what happens when you land in a, when you change of direction and when you're landing at the same time, when you're not balanced, how much of pressure it puts on the knee joint. It's it's a huge amount of emphasis done on this to avoid change of direction and landing at the same time, which can cause a lot of injury to quite a few players. See, she did it already by just when she was receiving the ball and when she was turning at the same time, and she landed on that left knee, and the knee went into a valgus position along with hip internal rotation and knee adduction. You'll be able to see that in the slow motion, what happens to the knee, what happens, look at that, and she did it already. So by the time you injure yourself, the knee cannot recover from that position at all. So some of the sample programs I've given you, I'm going to leave this slide for some time for you to look at it. Some of the exercises we can do. We all must do all these exercises. On a day-to-day basis, I do all these exercises. Every morning, I try to do some of these exercises to keep myself fit, to keep myself going every day. There's no point in avoiding. The more we're going to do, the better we understand these exercises. The more we understand about these exercises, which muscles is working at what level, we are able to administer this to our clients and our patients. Irrespective of the age, you'll be able to clearly understand how this exercise helps, how much it plans, how much it's able to reorganize your musculoskeletal system that balance your core versus your neuromuscular landing. Although if someone who has some biomechanical issues with a reduced notch or reduced ACL size or increasing tibial plateau difference or posterior tibial positioning, so we can help them with these exercises to somewhat control their condition, and that helps them a lot with their landing position. Their technique and the amount of efficient movement will improve, thereby fatigue can be minimized to some extent when you do all these exercises. I have put all these exercises, not all the exercises, some of these exercises as in a video platform. So hope you're all able to see it. I'm going to change it to the next level. Some of the dynamic warm-ups we can do. Some we call it as a high knee up and the heels up, opening gait, closing gait, and scissors, skipping, walking lunges, some jogs before. All this helps them. I'm going to show some of these change of direction maneuvers in this video. You can see what that thanks to Erica, who graciously agreed to do this video for me. And this is one of my client who's actually rehabbing with me for his revision of left ACL, and he's doing the skaters hop, and this is side to side hop. How much some of these exercises plays a major role in managing or preventing these injuries. This person who's doing there, Josh, actually not only has a left knee problem, but his right knee is also poorly controlled. You'll be able to see that the knee always goes into a valgus position. We are trying our best to correct for him. This is the box jump variation which Erica is doing there. She's going double to single, single to single, and single to double also in this depth jump or the drop jump. This is similar to the landing score that we do for persons, how well they land with their knees and how their body position when they land from, say, a 1-foot box. So how they knee stability as they do. So from single leg to single leg is what she's doing. Now this is a lateral hop over a hurdle. So sometimes you can use just your weighing or your dumbbell to use it as a hurdle for you to train all these people. You can do side to side, you can do anterior posterior, you can do rotational stability also with these. So some of the other exercises I just wanted to show you guys is the RDLs and the balance exercises that I always prefer to use. Star excursion balance testing is a very good tool actually. We use this in our clinic and we measure it, and it's a very valid tool. But there's a problem here, which with the inter-rater reliability of this testing is sometimes not great because the measurement is different between person to person. But quite often, there is a group called a mat movement, they call it as. They use a mat with which they measure the balance and exercises, which will also very important to do. These are some of the drills that you can do with your clients and improve the knee stability and the exercising for all these to improve the hamstring. On the left side, I have shown you some hamstring, how the hamstring can be moved. We have a nod board, and this is the Nordic hamstring measurement also that we use for quite a few people. Bridges, glute and hamstring bridges helps to activate the muscles. A lot of eccentric control on these ones, along with the Nordic. And the deadlifts. They are all very good exercising tool to do, and you can do them as a warm-up also. So this is the single leg squat, which Erica is doing there, and you can see how the hip and the knee, how the hip, knee, foot, and ankle position is maintained there, and it's kind of a pistol squat she's doing there, but our emphasis that I can show both the front and the back on the mirror. You'll be able to see once again how the knee is under control, how much her hip and pelvis is in balance, and how much she's able to forwardly flex, and how nicely she's able to control it. This is the importance of a good technique of your exercising. So the key home information that you're going to take up is from this quick webinar is that structured warm-up is very important that you can do before every training and game, and both as well in pre and in season. Duration at least for 15 to 20 minutes. Include various strength exercises, plyometrics, proprioception, dynamic stretches. Focus on a good, correct jump landing instructions, good cueing to all your athletes. Focus on correct cutting, pivoting movements. You must understand how the sport is played, and you should also try to mimic in their training maneuvers, and proper feedback to athletes. That's very important. And implementation, especially amongst the adolescent pubertal females, very important as early as possible. The more we're going to put them into athletic training with all the kids, that will prevent this injury happening. I think in the next 10 to 15 years in India, we're going to see a lot of women taking more sports in different variety of sports. There's a high likely chance that ACL injuries may be more prevalent. Everybody in this platform would be able to see more ACL injuries, I'm pretty sure. So ensure that some of these principles, along with the future researchers, if you're up to date, you'll be able to minimize the risks of injuries rather than thinking about preventing, because we are still finding hard to prevent this condition. So some of the references that I have done here, and I want to show you a video how some of the exercises being done using this prevention program. Thank you so much, everyone, for listening. Thank you, Chandru, and thank you, Duna and Rupesh.
Thank you, sir, for your very nice presentations. And I think we can go now for the question and answer session, a very quick one. Dear participants, if you have any questions regarding this topic, please post your questions in the chat box in Zoom. And dear participants in our Fitness and Rehab India YouTube channel, you can also post your questions there. We will convey your questions to our respected resource person, and you will get the answer. You can now post your questions.
Hello. Hello.
Yes, yes.
Hello, yes.
Hello.
Yes. I was disconnected, reconnected now. Yes.
Okay, there is a question from Santanu Mollik. Sir, when can we start exercise after injury?
Exercise after injury, we normally start on the first day itself. The first day means the day of surgery, we call it as a day zero. The day on the following day is the first day. Straight away, without they seeing the physiotherapist, they won't leave the hospital. We discharge our patient unless and until they don't have any complications or any other problem post ACL or the surgery. We always discharge the patient the following day. And along when they leave the hospital, they are given certain exercises to do, and they will be starting them. Not only that, we ensure that all these ACL surgeries, they do a prehab, means before the surgery, most of the surgeon, all of them for 6 to 8 weeks to do their rehabilitation, except in the elite and the sub-elite group, where sometimes we we continue to have a bit of a prehab, or sometimes we may not able to do that purely because of the club influence on that. But it's worth to try a prehab program, and then the ACL, and then the following day itself we start all the exercises.
He extends his questions with how long it will take in proper recovery.
Again, we are not based on a time-based management at the moment. I would say we are going per person, how the person is able to compare their side to side. Say, for example, if they are able to do a good single leg sit to stance, are they able to do the same on the right side? Even are they able to perform better, at least 10% better than the other side? We don't want them to be under any 5% or even change. For example, if I'm able to do a single leg squat 20 times, I want my right side, if the right side is injured, to be at least able to do 20 to 22 times in a better position. That is very important. And there is certain scales and the tools that we use. There is a Melbourne ACL protocol that we use, which has all the different 5 stages of return to sport. And we go by, not by time. If you go and look at all the research, what they say is don't go by time. Don't have a fixed period that this person must be able to run at 4 months. Or they should be able to do return to sport by 12 months. You know, there is no category. We shouldn't be doing that. Rather, we should be able to look at how the person is able to look at all these risk factors that we saw, whether they are able to control their neuromuscular levels, whether they are able to perform their movement better, whether they don't have any fear of moving. We use questionnaires, subjective questionnaires, IKDC questionnaires you can use to understand how the person is confident to do it. That is what is more important, I would say, rather than having a fixed time.
Next question comes from our YouTube viewer, Tejaswini. She asking, yes, will hamstring stretching along with strengthening minimize the risk of ACL injury, sir?
Yes, definitely. I would say that that's what one of the risk factor we found, the quad hamstring ratio, which is, or we call it as the other way, HQ ratio, hamstring quad ratio. The quadricep dominates quite often, and there's a chance for them to cause a lot of anterior tibial translation if that's the case. And hamstring also, part of the hamstring forms the ancillary tendons, and that to some extent limits that kind of action if there's a chance for them to do external tibial translation or rotation. And along with the hamstring eccentric control, prior to the training or the games or the activities, have shown a reduced recurrence or reduced occurrence of ACL injuries. And some of the programs, prevention programs that we quite often use, there are soccer prevention programs are there, like in a FIFA 11 plus, as it has moved on to now. There is Australian football prevention program, netball prevention program is there. There are different sports have come up with their sport-specific warm-ups and drills and programs. Quite of the other exercises been overlapping each sport, but it all works together really well. If you're able to understand the sport and if you're part of any sport, if you do those exercises as a prevention program, yes, the minimize, we have seen quite a bit of change actually.
Thank you for your answer, sir. And guess from who next message comes? It is from your guru, Lakshmi Prabha madam.
Okay.
She actually thanked for a nice session, and she's having a class, so she could not greet you at the end actually.
Oh, that's okay.
Okay, any more questions, guys? You can post in chat box.
Thank you so much, Lakshmi Prabha madam, for your presence till the end of the presentation. And yeah, I have seen the messages for SATHYA, and also you have left a message for me. Thanks for referring SATHYA so that we could have had a very good session actually. The knowledge sharing and information he gave is very useful for Indian physios. This is how we will learn and grow internationally. Thank you, madam.
Thank you.
I would like to register this. That's why. Sorry to interrupt. Then we can take any questions now from YouTube,
no
madam.
No more questions,
please.
Sir. No more questions there, sir. We have completed the session, I think.
Rupesh there?
Yes, sir.
Okay. So we will conclude. Any questions in your chat box? Sometimes it happens. Personally, they will message.
No messages here, sir.
Okay. Then we will conclude.
Yeah, sir.
Once again, thank you so much, Sathya, for your wonderful session. And
Thank you so
I
much.
think,
Thank you.
what's the time there now?
It is nearly 2 o'clock, 1:59 in the afternoon.
Afternoon. Okay. Hope we didn't disturb you in the night time.
No,
I was a
no,
little bit
it's
worried
okay.
about it. And yeah,
It's okay.
it was a very wonderful session. And
Thank you
I
so
thank
much.
all the participants today. And the whole India, even the whole world is celebrating Physiotherapy Day by having a lot of webinars. Still, we got more than 30 persons attending our webinar. Yeah, so I'm so happy about it. And I thank all the Zoom meeting participants and also Fitness and Rehab India YouTube channel viewers also. And I thank ExRxIndia team members, Dr. Vairav, Dr. Rupesh, Professor Duna, and all the resource persons who are taking webinars today all over the world. Because today is a World Physiotherapy Day, and I wish everyone again a happy World Physiotherapy Day. Thank you all.
Thank you, Chandru.
Thank you, sir. Bye-bye, sir.
Thank you.
Bye-bye.
Thank you, Duna, for
Happy
organizing.